Good afternoon. My presentation is entitled Biomarkers in Pediatric Kidney Injury. The main problem in acute kidney injury is that the diagnosis is delayed and therefore the treatment is delayed. The current diagnosis and treatment of acute kidney injury is woefully delayed, and that is illustrated in this acute kidney injury continuum cartoon, which goes from normal to risk of AKI to damage to functional injury, illustrated by decrease in GFR and kidney failure and its complications. And what we can see is that we are pretty good at diagnosing functional kidney injury when the GFR is already decreased using biomarkers of glomerular filtration such as serum creatinine and cystatin C. But what we need to do is to go to the damage phase, because in the damage phase there is already subclinical acute kidney injury, but we don't recognize it because of the renal reserve. So if we were able to identify the early damage phase, that would be very advantageous for us because then we can start treatment early. And the damage phase is assessed by new biomarkers of structural kidney injury, such as NGAL and the cell cycle biomarkers TIM2 and IGF-BP7. We will be primarily discussing NGAL in the topic today. So we know that serum creatinine is the current gold standard for acute kidney injury diagnosis. However, even normal serum creatinine varies widely with age, gender, diet, muscle mass, muscle metabolism, medications, hydration status, and especially in the scenario of acute kidney injury, serum creatinine can take several days to reach a new steady state. And we all know that more than 50% of kidney function can be lost before serum creatinine even begins to rise. A great example of this is living-related donor kidney transplants, where the donor, after donating one of his or her kidneys, still maintains normal kidney function. But there is an urgent need for early diagnosis of acute kidney injury because the early forms are reversible, and there's a direct correlation between the duration of injury and the resulting mortality. And we now recognize the phenomenon of subclinical kidney injury, which increases the risk of mortality and morbidity even if the serum creatinine is normal. And so early diagnosis will enable timely institution of effective treatment. The early diagnosis therefore requires better biomarkers of structural kidney injuries and not simply the functional injuries, the biomarkers that we currently have, such as serum creatinine. So how do we identify these biomarkers? Well, they have been discovered serendipitously. And we and several others have used many unbiased gene analyses, such as genomics and next-gen sequencing, looking for changes in kidney gene expression following acute tubular injury. And in many studies done thus far, reviewed here recently, the most upregulated gene and protein in acute tubular damage is this protein called NGAL, and we will focus on that today. There are more than 150 publications that show that, and in addition, there are unbiased proteomic analyses for detection, direct detection of biomarker proteins. And those have shown again NGAL and the cell cycle biomarkers as excellent markers for early damage to the kidney. And there are more than 30 publications now in the urine and blood from human kidney injury models. So let's talk a little bit about NGAL. How was it discovered? So NGAL stands for neutrophil gelatinase associated lipocalin. It was first discovered as a small 25 kilodalton neutrophil secondary granule protein. It is normally present in small amounts and is also produced in epithelial cells of the lung and the colon and the kidney tubules, and it's a bacteriostatic agent. Here's what we found when we looked at a mouse model of ischemic injury, where we injure both kidneys for 30 minutes with ischemic clamping and then allow reperfusion to take place. And in this model, the serum creatinine goes up 24 hours later. But if we take a small piece of the kidney and stain it for the NGAL protein, within 3 hours for sure, you can see that many of the tubules are positive for NGAL. And here's a high power view of the tubules, two tubules with a lot of punctate distribution of the protein NGAL. And what you can also see is that there are many dots in the lumen of the tubule, and we confirmed it with a different kind of stain for the NGAL protein, which again showed up in the tubule cells, but also in the tubule lumen, which gave us the idea that the NGAL protein secreted by the tubule very early after injury may also be detectable in the urine. And sure enough, that was the case. In that same mouse model, creatinine goes up in 24 hours, but really the first urine drop that comes out of this animal model, certainly within 2 hours, as shown here, is very positive for the NGAL protein. So it is clearly a urinary biomarker for very early tubular damage because it appears within 2 hours, whereas serum creatinine takes 24 hours to appear in this model. Having shown that and having done many other studies, we then created an ELISA for that protein, and then we partnered with industry to take that ELISA assay and put it onto standardized clinical platforms. So now this test can be done in any hospital, in any laboratory, using very standard machines that are already present in your laboratories. And that has led to an explosion of studies using NGAL as a biomarker of acute kidney injury. And we will briefly review 3 clinical situations: cardiac surgery, critical illness, and nephrotoxins. And we will look for NGAL as a marker of tubule injury prediction in these scenarios. We will also look at NGAL for differential diagnosis and finally for prognosis. And I will say that most, if not all, of these studies were started and pioneered by pediatricians in pediatrics and have now been confirmed in the adult population. So let's start with the cardiac surgery population. This was a study that we published in the Lancet, where we looked at 71 children undergoing cardiopulmonary bypass, and we collected urine and blood and measured NGAL before and serially after the injury, after the surgery. And we defined acute kidney injury based on the KDIGO guidelines, 50% increase in serum creatinine from baseline. And in our cohort of patients, that occurred 1 to 3 days after the surgery. So the diagnosis of AKI using the functional marker was delayed by 1 to 3 days. In the same patients, when we measured urine NGAL, shown here on the y-axis, and this is time after bypass in hours, shown on the x-axis, you can see that in the red line, the patients that never developed acute kidney injury continue to have very low levels of urine NGAL. Whereas in the blue are shown the urine NGAL of patients who subsequently had an increase in serum creatinine 1 to 3 days later. You can see that the urine NGAL went dramatically up within 2 to 4 hours after injury, and it stayed up throughout the 5 days of this particular study. So it was not only early upregulated, but also sustained in patients who subsequently showed an increase in serum creatinine. And we did the receiver operating characteristic curve, which is sensitivity over 1 minus specificity, which is one way of describing the accuracy of the biomarker. And when the area under the curve is 0.75 or so, that is a good biomarker. When the area under the curve is 0.9, that is an excellent biomarker. In the case of urine NGAL in our study, this was the ROC curve, which showed that within 2 hours, the urine NGAL area under the curve was 0.99 for the prediction of acute kidney injury. So what that told us is that in 99% of the patients, we can predict who is going to get an increase in serum creatinine much later if we just measured a drop of urine within 2 hours of starting cardiopulmonary bypass. Not shown here is that it also works very well in the plasma with almost the same area under the curve. Well, after that, there were a number of additional studies done in both urine and plasma in the setting of cardiac surgery. And when we reviewed this way back almost 10 years ago, there were already 30 publications with thousands of patients. And the area under the curve was maintained at 0.82 to 0.83. And therefore, this biomarker stood the test of time and was repeatedly very, very diagnostic of acute kidney injury in both adults and children using either urine or plasma for the measurement. Let's go into nephrotoxins. One common nephrotoxin we all use is contrast, and this is a paper that we published in 91 children receiving contrast agents. And we again measured urine and blood, NGAL before and serially after the contrast administration. The definition of acute kidney injury was the same as before, 50% increase in serum creatinine from baseline. And in those patients that had AKI, it took at least 24 hours for the serum creatinine to go up from baseline. In comparison, shown here is plasma NGAL on the left-hand side and urine NGAL in the right-hand side. In both cases, within 2 hours, we saw a dramatic increase in NGAL in the plasma and the urine in patients who subsequently developed contrast-induced nephropathy, which was a diagnosis that required at least 24 hours to occur. The areas under the curve were again excellent for both urine and plasma NGAL within 2 hours of giving the contrast, 1 drop of blood or urine, and that we were more than 90% accurate in predicting acute kidney injury in these children. And that has again been multiply confirmed by several studies, both in adults and children, with the area under the curve maintained very, very high at 0.91 to 0.94, again suggesting that this biomarker has clearly stood the test of time as a diagnostic agent for contrast nephropathy. Let's look at differential diagnosis. And here is a study that we did as a multi-center prospective study looking at more than 1,600 patients who were admitted from emergency departments in 3 different centers. And we measured urine NGAL prior to their admission. And we defined an intrinsic acute kidney injury as a 50% increase in serum creatinine, which was sustained for at least 3 days despite fluid and other therapies. So this is true intrinsic acute kidney injury. This is structural acute kidney injury. And we defined pre-renal acute kidney injury as the same increase, but which was reversed with fluids within 3 days. So this is functional acute kidney injury. There is no real damage to the kidney. And this is true intrinsic acute kidney injury where there is structural damage to the kidney. In both cases, there was a 50% increase or more of serum creatinine. So using serum creatinine at the time of admission, we could not differentiate between these 2 conditions. What if we used urine NGAL at admission instead? This is what we found. These are normal patients, and these are patients with chronic kidney disease. And these are those patients who had an increase in serum creatinine, which was reversible pre-renal acute kidney injury. In contrast, these are the patients with true intrinsic acute kidney injury who persisted with high serum creatinine for more than 3 days. And look at the urine NGAL levels in these 4 groups. This group with true intrinsic acute kidney injury had a very, very elevated urine NGAL at the time of admission, straight from the emergency room at the time of admission. We were able to distinguish this group of patients and predict who is going to get a sustained increase in serum creatinine. And I've drawn a blue dashed line here, which corresponds to a urine NGAL value of about 150. And that was a clear determinant because all patients with true intrinsic acute kidney injury had a urine NGAL level above that, whereas all patients with pre-renal acute kidney injury had a level well below that. So just remember this number 150. We'll come back to that. What about prognosis? In multiple studies, we did this multi-center analysis, which showed that if you take the area under the curve reported in multiple studies. All of these are intensive care patients who subsequently got acute kidney injury. At the time of ICU admission, we were able to predict with high accuracy who is going to need dialysis and who is likely going to die. So it is a very good prognostic marker. And early NGAL measures, in addition, provided what we call as added value. And to do this, we did a very large study of more than 2,300 critically ill patients from 10 different centers. All of them had urine NGAL measured at admission. And we used the same intrinsic acute kidney injury diagnosis criterion. What we were surprised to find was that about 20% of the patients were positive for NGAL, meaning had high levels of NGAL, but did not have an increase in serum creatinine. So we were very puzzled by that finding, and we wanted to find out what that means. What is the outcome of these patients with initial positive NGAL, even though the serum creatinine remained normal? And we were shocked to find that the patients who had a positive NGAL did much worse. So these are this group of patients, and each of these is a large number of patients. These patients are positive for NGAL but negative for serum creatinine. But look what happens to their in-hospital mortality, shown here in gray. And this composite outcome of in-hospital mortality and renal replacement therapy initiation. A dramatic increase from the patients who were negative for NGAL and negative for serum creatinine. So what this told us is that the early NGAL measurements provide that added value. It tells us who is going to get acute kidney injury, who is likely to need dialysis, and who is likely to need care for in-hospital mortality. So we were then able to differentiate 4 stages of kidney structure and function. And we start with this in the bottom left, where the serum creatinine is normal, urine output is normal, and the urine biomarker is negative. That's a healthy kidney. There is no tubular damage, no excretory dysfunction. Once we start getting dysfunction, we move from left to right here. When the serum creatinine becomes elevated, the urine output drops, but the urine biomarker still stays normal. And this is a group of patients who have excretory dysfunction, but no true intrinsic tubular damage. Those are typically patients who have volume depletion, who have pre-renal acute kidney injury, or mild congestive heart failure, or patients on diuretics. Turn to the top left. These are patients with normal serum creatinine and normal urine output, but they have the increase in urine biomarker, just like the study I just showed you. These patients then do have tubular damage. It is not bad enough to cause an increase in serum creatinine yet, and so they don't have excretory dysfunction, but they clearly have subclinical injury. And as we have shown, this group of patients do have higher morbidity and mortality. So this concept allows us to differentiate pre-renal acute kidney injury from this condition, which is subclinical kidney injury. And when both creatinine and urine NGAL are upregulated, those are the patients who have severe damage to the kidney, sepsis, ischemia, nephrotoxins, and these are the ones that have the worst prognosis. So many studies have been done using NGAL, and the meta-analyses of all these studies that are shown here, many thousands of patients now published in the literature, tells us that the diagnostic accuracy for early AKI detection using NGAL is very high. And looking at all these studies, we can come up with some cutoffs for urine NGAL and for plasma NGAL. And when the urine NGAL or plasma NGAL is less than 50 nanograms per ml, that effectively rules out acute kidney injury, no matter what the serum creatinine is. And when the urine NGAL is high, greater than 150 to 250, that strongly predicts acute kidney injury, even if the serum creatinine is normal. So those are some of the lessons that we have learned over the years using all of these meta-analyses. And that has allowed us to propose the utility of this biomarker and other tubular injury biomarkers in the clinical settings. First of all, we measure biomarkers, and we do this routinely in our clinical operations. We use it when structural acute kidney injury is clinically suspected or needs to be ruled out. For example, in the ICU setting, we use it to predict structural acute kidney injury, and we also use it to predict outcomes and recovery from kidney injury. For example, after high-risk cardiac surgery in patients with sepsis, fluid overload, extended mechanical ventilation, multiple vasopressors, you all recognize that these are all high risk for acute kidney injury, and an early NGAL upregulation indicates for us or gives us the red signal or a red flag that there is impending acute kidney injury that is coming our way. And in patients who are already on dialysis, it is a useful biomarker to indicate renal recovery from the injury, such that the biomarker will begin to normalize before the urine creatinine or serum creatinine normalizes and before the urine output normalizes. We frequently use it after nephrotoxin use to predict nephrotoxicity and to adjust the dose of the nephrotoxic medication, especially on patients who are on multiple nephrotoxic antibiotics, patients who are at high risk for CKD or AKI, who get contrast, and chemotherapy patients. We use it quite a bit in our transplant patients, both bone marrow transplant patients as well as solid organ transplants. Specifically in the case of kidney transplant, we use it to predict delayed graft function. We use it in patients with congenital anomalies of the kidney and urinary tract to determine the extent of structural kidney injury in those patients. And in the outpatient or urgent care setting, we again use it to predict or rule out structural AKI. For example, a patient who comes in with dehydration and increased serum creatinine, we use these biomarkers to determine whether they have pre-renal volume responsive acute kidney injury or do they have true structural injury, especially if the creatinine is already elevated. And we use it to differentiate between reversible pre-renal azotemia and structural AKI, and that is very useful for risk prediction. And now more recently, we've started using it for early diagnosis of true acute kidney injury due to urinary tract infections, especially pyelonephritis. Patients with true UTIs have a high level of urine at the time of initial urinalysis. So our approach is as follows. First of all, like I said, we only measure if it is clinically suspected or needs to be ruled out. And when the NGAL level is low, that to us effectively rules out acute kidney injury. And in those patients, we would repeat the measures only if it is clinically indicated. If it is in the gray zone, 50 to 150, then we would again repeat the measure if it is clinically indicated. But if it's above 150 to 300, that tells us that that patient is already at high risk for structural acute kidney injury. It doesn't matter what the serum creatinine is. It doesn't matter what the urine output is. If the NGAL is high, that patient is at high risk for structural acute kidney injury. In those patients, we would monitor the urine NGAL daily, sometimes twice a day. We would monitor the patient, monitor fluids, electrolytes, kidney function. We would certainly avoid nephrotoxins in these patients. We would maintain their blood pressure, and we would consider something like a furosemide stress test and other one of several preventative measures that we can use for early treatment of impending structural acute kidney injury. And if it is really very high, more than 300 to 500, those are the patients that we are very convinced are at very high risk for severe structural AKI. These are patients that are destined for needing dialysis and are patients who are destined to potentially have a high mortality rate. We will keep those patients in the ICU setting. We will maintain blood pressure, stop all nephrotoxins, and we will indeed consider early initiation of dialysis even before the traditional indications of dialysis, such as fluid overload and hyperkalemia, occur. And we enroll these patients in therapeutic trials. And an example is shown here. When we see a patient who is at risk, for example, in the ICU, we measure the NGAL levels, and if the NGAL levels are normal, we would predict that they don't need any specific treatment for AKI, and the outcome is that their NGAL stays normal and there is no AKI. If we measure NGAL and it is already elevated, then we randomize them into either routine care, that is, for example, a placebo, or specific interventions, for example, early renal replacement therapy. And what we would predict is that the patients with high NGAL who are treated with the placebo will continue to have high NGAL and will end up with more acute kidney injury. Whereas the patients with high NGAL who respond to the treatment, we can use NGAL as an indicator of effectiveness of therapy, and they will have a reduction in NGAL, and ultimately they will have less acute kidney injury. So I'm going to end up with this slide that again shows all the settings that we normally use kidney injury biomarkers such as NGAL in our clinical practice. Thank you for your attention. I'm happy to answer any questions that you might have regarding biomarkers of acute kidney injury and specifically about NGAL. Thank you very much.